And all right, I've got a couple of review questions quick. So this might be an example of a more basic test question. By basic, I mean it's not case-based. So it's really focusing on a specific attribute of either a drug or, in this case, a combination of drugs, potentially. So what we're looking at here, following combinations would be reasonable to start if your goal is to provide broad-spectrum coverage to include possibly resistant gram-positive, gram-negative, and anaerobic bacteria. So anybody want to take a stab at this one?
B.
I heard some A and B. What for some people who said, all right, for somebody who said something other than A, why is A incorrect? Or why wouldn't you pick A? That's right, yeah. So when we're talking about these general terms here, when we talk about resistant gram-positive, usually that means MRSA. Certainly could maybe mean other things, but MRSA is usually what we're targeting there. Gram-negative, remember Pseudomonas is kind of our marker for that one. There's certainly other gram-negative species that cause lots of problems, but Pseudomonas is kind of the one we associate with what's broad spectrum and what's a little bit less narrow spectrum, or more narrow spectrum. And anaerobic bacteria. So there's only a few drugs that actually cover that, and D is the correct choice there. So Zosyn covers Pseudomonas, Vanco covers MRSA, and Zosyn also picks up your anaerobic bacteria. B or C is also a pretty broad spectrum option, and it works for a lot of cases, but it's missing Pseudomonas and it's missing the big anaerobe we want to cover, right, which is Bacteroides. So that's the one that ceftriaxone just doesn't pick up. Otherwise, ceftriaxone is a broad spectrum antibiotic. It just is missing a couple things here or there. So very versatile. And again, that combination, like that's first line for meningitis. So we use it for severe infections. It's just not the most broad spectrum. D, we wouldn't, first of all, the azithromycin is just wrong unless you're, we'll talk about azithromycin and its goal, but on its own, without something else in there, its utility is minimal. And for severe infection that you're targeting really broad spectrum therapy, the only time you really add azithromycin on is if you're looking at targeting atypical pathogens. So for like a community-acquired pneumonia, you could start something like ceftriaxone, which is going to cover strep pneumo really well, and azithromycin, but you never use azithromycin by itself. And the problem with that combination with linezolid is that there's really no gram-negative coverage here to speak of. Linezolid's an okay drug for gram-positive resistant infections, but it's not first line, just because vancomycin is a little bit more of an effective killer. Vanco's a cheaper drug, and we're just more comfortable with it, to be honest. Linezolid has some odd side effects. It interferes with some mental health medications. It's okay. It's not like we avoid it, but it's just not as commonly used for those reasons. Okay. Question number 2. Which of the following medications would not be appropriate for an infection caused by Pseudomonas? C. All right. So if you're paying attention for the last slide, you should get this one here. All right. And remember, which one of these is the only oral option we have to treat Pseudomonas? Anybody got that one? It's a little trickier question. I wouldn't ask you that on an exam, but I'm just throwing that out there. I heard Cipro from a couple people, so I'll say Cipro. Yeah, Cipro is correct. So all these are IV only except for Cipro. Yep. And remember, even though some 3rd/4th generations cover Pseudomonas, like Ceftaz and Cefepime, they don't have a 3rd generation oral equivalent that covers Pseudomonas. So cephalosporins, that's one of the biggest differences IV to PO when we're talking about drugs, is that 3rd gen cephalosporins IV are generally much more active against advanced gram-negative infections than our PO counterparts. Even though the PO counterparts are pretty good, they're just not quite as good. Why that is, I don't know. They're all different structures, so I assume it has to do with the molecule and just be more susceptible to bacterial defense mechanisms. Okay, number 3, based on the below patient allergy information, which of the following antibiotics would be least likely to cause an adverse reaction? So got a patient here who's reporting penicillin hive, cephalosporin rash, and fluoroquinolones tendon pain. And all things considered, you want to prescribe something. Which one would be least likely out of those choices to cross-react? Doxycycline. Okay, good. I'll point out something random about doxycycline is that it's part of the tetracycline class, right? So a lot of times you'll see tetracycline listed as an allergy or tetracyclines as a class listed as an allergy. So remember that doxy falls under there too. You also see that on lab susceptibility reports. They often report tetracyclines as a class. So you won't see doxy show up like under Staph aureus, but you'll see tetracyclines. And if you see tetracycline susceptible, you can assume doxy is going to work for that. Same thing, if tetracycline is resistant, we assume doxy is probably resistant too. Okay, so remember some basic ID stuff, things to consider when we're talking about patient care, source of infection, and then with that should become the most common pathogens associated with that particular source. Recent antibiotic use, so have they failed a course recently? Have they been exposed to something? Have been on broad spectrum antibiotics for a long time? Previous exposure, what is their family history like? Is all their family members have strep throat, and this person comes in with a sore throat? It's probably strep, right? Previous cultures, do you have culture data? A lot of times with our recurrent UTI patients, you can go back and look at a number of cultures, and it's really helpful. Every once in a while we catch something where it's like, you prescribe this to this person. If you just would have looked at the culture history, you'd know they've had resistance to this for the last 6 urine cultures over the past year. So that's a really easy thing to catch. Make sure you're checking that stuff. Tissue penetration. We'll talk a little bit about that. That's a little bit more advanced, and it really only applies to certain things like osteomyelitis, prostatitis. It is the difference between like a pyelonephritis case and a UTI, a common UTI like a bladder infection, or I should say cystitis. So that would be something we'll approach that later. Allergies, of course, infection parameters. So how much of this stuff is your patient showing? Like, do they actually have a true infection? This gets complicated. Like in my realm, we see this as an example where we have like an older person coming in with possible urinary tract infection. They might not have any of these things, but you might think they do anyway. So it's like, can you get some more information? Can you culture their urine, run a white cell count? They might not have a temperature. They might not appear sick really, but what are some other things we can look at? All right. Sorry, I put lots of stupid Google images in my slides. I don't know why I did that. I should probably delete them, but you can laugh at them. It's fine. All right, and I like pictures of ID, and gross pictures are fun. So cellulitis. Start here. So I usually approach things this way as opposed to giving you a specific case to talk about when we talk about where we treat medications, because especially with ID, it's very difficult without to talk about it from empiric and then specialized. So you'd have to do lots of different cases. So kind of use your imagination at how a patient might present with cellulitis, and I'll walk you through some of the more common targets bugs we target, and then which drugs we pick for those. So anyway, cellulitis can present in a number of different ways. Usually you're looking at something that's raised, swollen, very red. It could be different organisms will show differently. So like a staph infection is usually more associated with purulent. Something like this, that's probably going to have maybe an abscess behind it, potentially. Strep infections might be a little bit more of a sporadic erythema pattern, not necessarily as pustule type thing. So again, it depends, and certainly you can have both in one, but usually the more severe cellulitis is almost always culture is staph, whether it's MRSA or MSSA is, that's a flip of a coin almost, but that's usually what I see come back in our cultures. But then again, strep infections, there's not usually much to culture. So if you're draining an abscess, it's probably staph, because that's what's usually going to cause a purulent abscess. If you are culturing somebody's skin because they have like kind of a weird infectious looking rash with maybe some beginnings of cellulitis, then that could be strep, but everybody's got strep on their skin. So most people have strep pyogenes and Staph aureus living on their skin, whatever type it is. So it's usually some kind of a puncture wound or something else going on. Maybe the patient's immunocompromised or not getting good circulation, like in the case of maybe somebody who has diabetes and doesn't get good blood flow to their lower extremities. That can put people at risk for infections like that. But everyone's got it. So if you swab somebody's skin, you're probably going to grow something. Whether it's actually a pathogen or not is a little debatable. Okay, so treatment of cellulitis, our basic gram-positives is what we're trying to cover here. So almost always with any type of cellulitis, you're looking at covering Staph aureus and strep pyogenes. And so that's where cephalexin and cefazolin come into play. For most basic cellulitises, that's going to cover the vast majority of patients. Again, it's a good option for people for preventative therapy too. So prior to surgical incisions, that's again why they use it. Those are the skin bugs they're trying to keep out of a surgical incision site. So usually pre-surgery and post-surgery, a few doses they do this. But for cellulitis, you're usually looking at 7 to 10 days of treatment. Either one of those should be more than adequate to cover both of them. Now, if it's MRSA, so you don't really know if something's MRSA right off the bat, which makes it a little confusing. You could look at patient history. So the patient might have exposure to MRSA. They might have a family member that has MRSA or has had an MRSA-related infection. Those are certainly questions you could ask. But a lot of times you don't know, especially if it's community-acquired. And so some of my providers will prescribe combination therapy right off the bat, and then they leave it up to my group to discontinue whatever is not necessary. So an example of that would be they prescribe cephalexin here, and then they will prescribe like a Bactrim as well. So they actually give them two therapies. Bactrim does not really cover strep at all, but it covers MRSA really well. So if the culture comes back growing whatever, that's where we can direct the therapy. So if it doesn't come back growing MRSA, we tell them to stop the Bactrim. Comes back growing MRSA, we tell them to stop the cephalexin. It's really common. And you could sub in doxy for that too. It's pretty common. MRSA, again, purulent drainage is the big thing to think about with staph infections generally, but then it's all about exposure. So they've been exposed to MRSA recently. Again, there is community acquired too, so it's certainly possible that they've had no exposure. I have no idea, and then they grow MRSA. When it comes to the PO options, Bactrim and doxycycline are our preferred agents here. They have the best coverage for Staph aureus empirically. Clindamycin covers staph and it covers MRSA, but Clinda's coverage is just a little bit dicey for staph in general. Like you're looking at maybe 80% coverage of staph, whereas Bactrim and doxy are going to cover like 98% of all staph strains out there. It's really good coverage against MSSA or MRSA. Clinda is just a little bit of a gamble. The only time I really use it is, well, we'll talk about a couple other infections where it's useful, but in this situation I might use it if there's a lot of intolerances or allergies to other agents. And the other thing it covers is some anaerobes. So if there's like a facial related cellulitis, it might be beneficial in some patients. It depends on what you're looking at though. Definitely more focused utility with Clinda versus Bactrim and doxy have a lot of broad use for really anything MRSA related. Linezolid, again, a second option there. It was expensive. Now it's relatively affordable, but it's still a slower killer, and it has a number of side effects that we don't like quite as much. IV options, all these come IV. Bactrim does come IV. We just don't use it a ton. It's got some odd IV dosing with it, and you can only infuse it at certain rates because it causes vein irritation. So we kind of avoid Bactrim IV unless we have to give it. But if you're going to give something for MRSA coverage IV, you're probably always going to start with vancomycin. Vanco, again, big picture here. Vanco is not broad spectrum. It really is an MRSA targeted antibiotic, and it's relatively inexpensive. So we do use Vanco a lot, and this would be a case where Vanco would actually work great. If you had a patient with coming into the hospital, you wanted to get them started on something IV, you weren't sure about what you're trying to cover, Vanco is a good choice, especially if you want that empiric MRSA coverage. Combination therapy, so you've got your MRSA agent plus your cephalexin, kind of like I talked about. You might add something else on, amoxicillin. Plain amoxicillin covers strep really well too, so you could do that. Most people will do the cephalexin because it's just got better staph coverage. So if you're going to do that combo thing, I'd recommend the either doxy or Bactrim plus cephalexin. Just make sure if you do that, there's some follow-up mechanism at whatever practice you work into, whether it be your pharmacy department, which is unusual, or you're following up yourself or somebody else's. Incision and drainage, I just put this on there, there's some debate over if you do an IND on a patient's abscess, whether you actually have to give them antibiotics or not. The recommendations are controversial. Some of the guidelines say you don't really need to. A lot of people do anyway. I think the idea is that it's hard to get rid of every single bacteria that's in there, right? You're not going to get everything out. So if you can get the majority of the abscess taken care of and then provide some sort of antibiotic to suppress reproduction and to kill the remaining bacteria, that can be helpful there. So most people will do it post-IND, especially if it's a significant cellulitis. Treatment length, usually 7 to 10 days. I stick to 7 days. I feel like it's pretty straightforward. One of the things I'll say about dosing on these, cephalexin is a 4 times a day medication for a cellulitis, which is not convenient for most patients. You could say some people will prescribe it TID in the hopes that the patient will actually take it 3 times a day, thinking that, oh, if I prescribe it 4 times a day, you just aren't going to be compliant with this. You're going to stop it halfway through. You're going to get sick of this. So they prescribe it 3 times a day in the hopes that maybe the patient will actually take it. Technically, 4 times a day is the correct dose, but 3 times a day is fine. I wouldn't ever call anyone out on that. BID, not appropriate unless you have renal dysfunction, or if you're treating a simple UTI, which is what we're talking about now. So if really for cellulitis, you want to up the cephalexin dose to at least 3 times a day. Doxy and Bactrim are twice daily, so they're a little bit more convenient to take for people. All right, any questions on cellulitis? I'll move into some more complicated things you might see for skin and soft tissue here. Puncture wounds get really tricky. And this is one of the questions I hate the most. It's like, oh, somebody has a super dirty shoe on and they stepped on a nail. What do you do? I'm like, I don't know. I mean, anything could be in there. So it's really hard to cover. It's not like you're going to admit the patient for like a shoe puncture or nail puncture on Vanco and Zosyn, right? That's ridiculous. So you have to take some of that with a grain of salt. I mean, yeah, shoes are dirty and they might have water on them, and water has Pseudomonas in it. Usually that's where Pseudomonas likes to live. So who knows what exactly they got exposed to. There are a couple things we look at. So again, the location. A lot of times they'll get like, they got a scrape from a rusty piece of metal or like a dirty piece of metal while they were working on something. Usually, unless we know otherwise, I mean, you can always go a little bit more broad spectrum and give them something that's going to pick up some anaerobes too, because you don't really know. I would stick to the basics. So cephalexin is probably going to still provide good coverage because you're probably still looking at gram positives. Now, what else is in that cut? You don't really know. Ciprofloxacin, Augmentin, those things will pick up some anaerobes and some gram negative species. So again, depending on what they might have come in contact with. Cipro will pick up Pseudomonas if it's growing like from a water exposure, the bottom of a shoe sole. With water, we actually, this is common in Minnesota, so you're walking around in a lake or something and get a significant cut on your foot or whatnot, you step on something sharp. Citrobacter is a common water bug, and Cipro covers that really well. So if you ever have a water exposure, Cipro is actually recommended to add on. You could do cephalexin and Cipro too. You could do a combination, or you could just do Cipro. It kind of depends on your appetite for risk. Cipro itself covers staph reasonably well. It doesn't cover MRSA, but it covers MSSA reasonably well. It also will pick up your strep species okay too. So you might be fine with just Cipro for a water cut like that. Again, it really just depends on what you're looking at. And always follow the culture data too. Culture it if you can. Let that guide your decision. We've had some issues where we followed up on people with this where they're just prescribed Keflex or cephalexin, and they ended up coming back and needing additional therapy because it just wasn't effective due to the Citrobacter growth. That's a really common water pathogen that gets into the wounds. Animal bites, wounds. This is another kind of common thing you might see if you work urgent care or emergency medicine. Usually there's a couple things you're looking at. A little trivia, dog bite or cat bite, which one's more likely to cause an infection? Cat bite. You guys probably have this already. Good. So cat bite's true. Cats have really sharp, long teeth, and they have lots of bacteria in their mouth. Dogs have stronger jaws with their teeth. Usually you might get more tearing of the flesh, but not as deep of penetration. That's really the key there. So Pasteurella is thought to be the oral microflora that's causing infections for post-animal bite, especially with dogs and cats. And Augmentin covers it really well. So any type of animal bite, usually Augmentin's the drug of choice. It's kind of an oddball, which is why I put it in here, but it's a common thing. We don't use cephalexin, we use Augmentin for those patients. Sanford Guide, I'll put a plug in for this. I'm not going to go through any other animal bites, but it has everything in it from bat exposures and rabies guides and all that type of stuff, but it has more practical things, like even a human bite, which you don't think of humans biting people that often, but think about somebody who got in a fist fight, punched somebody in the mouth, and has a big gash from a tooth like on their hand. Those can cause pretty nasty infections too. So little tip, that's also Augmentin. Most of the things when it comes to oral flora and cellulitis are possible reactions that are possible infections from an oral bite. That's going to be Augmentin generally. All right, getting a little bit more advanced here. Diabetic foot ulcers are usually due to circulation issues, and they grow over time. This doesn't happen overnight, right? So this is a neglected care here. That's why we have to be really important when examining our diabetic patients, making sure we're checking their feet, or hands and stuff, just making sure their extremities are getting checked every visit. Now, these are usually polymicrobial. It depends on how far in the ulceration is, but generally you'll know a diabetic foot ulcer the moment you step in the room. They smell pretty bad, and high risk for amputation, just because, think about it, the reason why there's already nerve damage here due to lack of blood flow, so you have issues with getting blood to the source. So how are you going to get antibiotics in there? That's a big trick, and if you come up with it, you'll probably make a lot of money off your antibiotic, but it's really difficult too. You have a lot of wound care, debriding, and stuff like that. Ultimately, you can pump people full of IV antibiotics, but actually getting it to that source is really challenging. So we certainly try, but you never know. And you might, despite your best efforts, you might have to amputate something at some point. So broad spectrum antibiotics, you don't know what's in there. If you culture that thing, you're probably going to go a lot of really nasty stuff. So whether it's going to lead you down any correct path into what's actually growing in there, who knows? You're probably going to get, again, a number of things. So cover your anaerobes, cover your gram-negatives, and cover your gram-positives. If somebody comes in with a diabetic foot ulcer, almost always like vancomycin or vancomycin, metronidazole, some combination like that. Check for bone involvement, and that would lead you to osteomyelitis. Osteo is really similar to skin and soft tissue infections. We just extend the course a lot longer. So osteo treatments usually go 4 to 6 weeks. And the only reason to think about this being a little bit different is that most antibiotics we use short term. So when it comes to using long-term therapy, a lot of them aren't as well studied for a month or two of therapy. So in this case, we have to make sure that we're giving them something that isn't going to be problematic over a long period of time. So like, for example, vancomycin over a long period of time can cause more issues with kidneys. It can cause possible ototoxicity. So we have to make sure that they're getting monitored regularly for vanco levels to make sure they aren't getting too super therapeutic. Also, bone penetration. Usually agents with good bone penetration I listed down here. So fluoroquinolones generally work well for osteomyelitis. Vanco's got decent bone penetration. Linezolid, clindamycin, and most all cephalosporins. So a lot of drugs have good bone penetration, but ones that don't would be like Zosyn. Zosyn doesn't have great bone penetration. It's kind of a big, chunky beta-lactam. It doesn't work quite as well. So empiric therapy for an osteomyelitis, somebody comes in with a nasty osteo and you don't really know what to do. Usually if somebody's got osteomyelitis, they hopefully have had some follow-up. I mean, this is a ridiculous picture, right? This looks as if somebody got their leg shattered and then there's a nasty infection going on at the same time. But if it's a more normal osteo, usually it's an extended cellulitis that somehow got bone involvement at some point, or a diabetic foot ulcer more likely that had bone involvement. So vancomycin, Levaquin, that's a common combination, or levofloxacin, and ceftriaxone, ceftazidime, cefepime, those would all be okay depending on what you're trying to target. I'd probably stay away from ceftaz just because it's a little bit more narrow spectrum and stiff to either ceftriaxone or just go with cefepime because it covers Pseudomonas and other nasty things that might be growing in a deep infection. Bone biopsy is kind of the gold standard. You can biopsy the bone and figure out what's growing on it and sort of narrow your therapy from there. Hopefully somebody's not going to be on all these broad spectrum things for 6 weeks. The idea is to narrow, then go from there. That's usually an ID thing, so unless you're going to practice an ID. And we do have a PA that practices in one of our ID groups, so it's certainly a career option, but you won't really do that part of the care. That should be an ID group that's following that patient. All right, derm only. I'm not going to talk about this a ton. We'll talk a little bit about derm products and things like that next, in the winter actually. It's the first lecture in the spring semester. So I'll talk about ointments and creams and how all those work and how they get into the skin and that type of stuff. So put that on hold for now. There are topical agents like bacitracin and mupirocin that are used for small lacerations, abrasions. They can also be used for prophylactic therapy too. So for example, like MRSA tends to colonize around the nares. And so if we want to get somebody MRSA free, you can try and like put mupirocin around their nose. So you do that sometimes to prevent transmission of that to other areas. Acne, we'll talk about that in depth during derm, so we won't go into that right now. ENT infections. You like my diagram here in case you guys wanted to know what ENT stands for? All right, so a couple of things we're going to talk about here. A lot of these are viral, so this is a little bit of a controversial area. Rhinosinusitis, again, most likely going to be viral. These are the things people come into and ask for antibiotics for, and 90% of the time they don't need them. They get them prescribed anyway. Problem is it's really hard to diagnose, at least from what I've read in my experience, it's hard to diagnose this as viral versus bacterial. So I get the question on, well, what would you recommend? If like you asked me, should I give this person antibiotics or not, I'd probably say, well, if they've been longer than a couple of weeks with the same symptoms, I think that's probably a sign that it's more than viral. Viral should, we've all had a cold in here, right? Unless you're a superhuman that I don't know about. You've had some kind of a rhinovirus, and it's going to resolve in a week or maybe less, maybe a little bit more, plus or minus a couple days. So if it goes on longer than that, yeah, that might be something to consider. Sometimes you can think of like the the nasal drainage, the thicker, maybe more bacterial, but I don't think that's necessarily true or proven. Some people do use that as a diagnostic tool. Anyway, that's all I'm going to talk about with diagnostics. Definitely not my cup of tea or my area of expertise, but certainly I get pulled into some of this stuff. So the controversy is if you want to treat for a bacterial infection, what do you do? When do you do it? So it's a clinical judgment call, of course, but usually Augmentin is pretty good at covering most of these flora that you're going to see in the upper respiratory tract. So strep pneumo, Haemophilus influenzae, and Moraxella catarrhalis, or MCAT, are going to be the ones that are most commonly seen for these type of infections. And Augmentin covers all of them quite well. Alternative agents, so if somebody has a amoxicillin allergy or a strong penicillin allergy, you want to go with something else, doxycycline will cover everything. Levofloxacin, fluoroquinolones cover them. Azithromycin has okay coverage. Again, it's not going to get the strep pneumo, but it's going to get the Haemophilus and the Moraxella pretty well. So you could kind of gamble on that and see if that gets better. I wouldn't do that for a pneumonia, but for a sinusitis, I might be okay with azithromycin as monotherapy. Otherwise, a third generation, second generation cephalosporin by themselves would work okay. Usually 5 to 7 day course is fine. By the way, I'm not going to test you on course length, so that's for your information. I won't test you how long to give a course of therapy for. Difficult to tell the two apart. 90% of people will get antibiotics for an upper respiratory tract infection based on some studies. So again, this is a huge area of inappropriate antibiotic prescribing. It's probably an area we should work on clamping down, but I'll leave that to you guys. It's not really my cup of tea. All right, they don't let me prescribe yet. Well, I can technically. Oh, anyway, talk about that later. Tonsillitis or pharyngitis. So we're talking mostly about strep throat here. So group A strep is the primary culprit. Group A strep's a little bit different than the strep we have on our skin. But it's highly susceptible to even the most basic antibiotics. So penicillin, plain old penicillin still works great for group A strep. If you do a strep throat, so the way our lab works, if we do a strep throat rapid test, which comes back very quickly, it'll tell you if the antigen is positive or not. If it's positive, we assume strep throat, treat you with antibiotics, go about your merry way. If it comes back negative, it reflexes to a culture. Now there's recommendations by IDSA to say don't reflex negative results to cultures for adult patients, because adult patients aren't really at risk for rheumatic fever. They aren't at risk for ongoing complications. Usually it'll basically be resolved at the end of the day. For children, you'd probably still reflex to a culture. But at Allina, we reflex everything. This lab just wants to do that. Who knows? Anyway, so a lot of times what I get back and what you might see in your patients if you do throat cultures is group C or G strep growing. This is actually normal flora, and technically you don't need to treat this. Now, if they're getting better on their own, I wouldn't recommend prescribing any antibiotics for it. If they have, sometimes we'll call these patients and they're like, yeah, I'm fine, I don't really need anything. You know, it was a couple days ago, now we got the throat culture result, they're improving, great, no antibiotics. Call them and they can barely talk to you and they're crying because their throat still hurts. You know, metaphorically speaking, right? Or maybe actually, it depends on the person. But you can use your judgment call on whether you're going to prescribe something for them or not. But again, it's basic penicillin for the most part. And we used to do this penicillin IM dose, and I think I mentioned this in the other lecture, but that's been very hard to get lately. So we've got a small stash of it at our hospital and reserve it for syphilis patients, just because syphilis patients tend to not be the most reliable group of people in the world, just from doing lots of follow-ups on syphilis over the years. And most of them don't even have phone numbers that exist in our system. So it's difficult to get somebody to agree to take a 10-day course, to follow up if they're taking it, and to make sure that you can call it in if you had a result come back that's positive and they weren't initially treated. So that makes the compliance aspect premium for that IM product because it's a one-time dose. So we don't use this for strep throat anymore until it comes back into full. You might see it in different health systems prescribed differently, but that's how we've been treating it, just because it's been a fairly valuable commodity. For people who have penicillin allergies, amoxicillin, if they have so that's not really an allergy related, but for example, penicillin orally as a suspension, if you're treating a kid, tastes kind of bad. Amoxicillin, according to people I've talked to, tastes a lot better. Don't really remember tasting that myself. Azithromycin is a good alternative for somebody who's got a severe penicillin allergy. So that's one we go to. It covers strep A quite well. Strep pneumo, not so much. Group A strep, it does cover quite well. Ceftonir, third generation cephalosporin would also be an option you could try. Tonsillar infections or more severe throat infections could have anaerobic or atypical involvement. So clindamycin will actually work pretty well to cover upper respiratory flora, and it also has anaerobic coverage as well. So that could be one for like a dental abscess, which isn't really on this slide at all, but or a tonsillitis might be something like that. Azithromycin is going to cover atypical pathogens, so you could add it on to something. Again, you probably aren't going to have to go that far down the rabbit hole with some of these, but something to think about. All right. Oh, I kind of skipped over this bullet point. You guys probably can read it on your own, but rheumatic fever, acute rheumatic fever is an immune system-related reaction to antibodies produced by group A strep. That's generally the reason why we eradicate. So we do these long 10-day courses in a person that would otherwise probably need a 5-day course to feel symptomatically better to try and eradicate as much group A strep as possible. So the risk, as one of my cynical providers says, the risk of getting rheumatic fever is substantially lower than the risk of having anaphylaxis to penicillin. So it is really rare. So he's like, I never prescribe it because that's why. I'm like, okay, well, he's kind of one in a million. So take his wisdom. He's very wise, but a little bit of a grain of salt there. But anyway, the point is that it's quite rare, but that's why we do that. If you're wondering why we do these long courses and why we try and follow up with kids, even if they're getting better, that's why. All right. Oh, otitis media. Control pain, consider one of two strategies. So if your patient comes in, it looks like otitis media, you can do immediate antibiotic therapy. The alternative is to have the person be observed for 48 to 72 hours of treatment. Now, if your patient's kid is screaming and they're freaking out, that's going to be hard to explain to them to do. And it's okay to cave in a little bit. Now, if the patient's parents are open to doing that, or if they're an adult patient and they're okay with waiting a little bit, certainly let them wait. Hopefully it resolves. I actually toughed it out for my son once. I followed all the guidelines perfectly, and it resolved like that. It was like right at like the beginning of day 3, it was done. So I think there is some truth to that, but again, you might have a really sick kid and a parent who needs to get on with their life or has 3 other kids they have to manage, and things get complicated. So it's not terrible to prescribe right off the bat, assuming your diagnostic tests are all confirmatory as much as possible. All right, so same bug, same treatment as other ENT stuff. Amoxicillin is going to cover everything. We don't really need to use augmentin. You're not involving more advanced flora, and kids usually don't have anything odd as far as infections goes, whereas amoxicillin might pick up some strange stuff in an adult patient. Kids, amoxicillin by itself without the clavulanate aspect should be fine. Azithromycin is okay for a pan-allergic kid or an amoxicillin allergic kid, and 3rd-generation cephalosporins. Usually if you trial, for these kids you see with repeat ear infections, you might end up getting them referred for like ear tubes or something like that. But in the meantime, amoxicillin courses, I would start with amoxicillin. If they fail that, maybe try augmentin. If they fail that, probably go to 3rd-gen cephalosporin. If they fail that, I'd probably make sure they're getting some sort of follow-up care in the meantime there to make sure there's some other option, because sometimes it's just the anatomy that's not working correctly until the kid gets a little older. If recurrence within 30 days, again, there's that. You could do Levaquin. Levaquin in kids is debatable. We'll talk about that during peds, but anyway, adults would be fine. Topical therapy. So topical therapy, whether you're going to do a topical otic antibiotic is if there's a ruptured tympanic membrane, and you're usually going to combine it with oral. Fluoroquinolones are the common ones, so Cipro is a really common one. There's a moxifloxacin eye drop or ear drop as well, and some of them are combined with steroids too. We'll talk about steroids at the beginning of the next module, but like dexamethasone is a common one that is an anti-inflammatory. Will work topically that way, so you'll see that prescribed for that. But for non-ruptured, I don't think there's really any indication for topical antibiotics. All right, conjunctivitis. Bacterial versus viral debate. Again, this is kind of like sinusitis. It's a toss-up sometimes, I think. Same bugs. Staph aureus is more common in adults, though. So where with kids with conjunctivitis, it's really rare to see staph. With adults, it's a much more common presenting pathogen. Topical antibiotics are usually all you need to do. Erythromycin ointment is something you could try. It's goopy and you can't really see when you put it in. I haven't put that in my eye, but I've put like a lubricating They make us do this in pharmacy labs. They're like, okay, I see what your patient would see. Okay, my patient's not going to see anything, so I'm never going to prescribe this. So unless you have like an infant that you can kind of gob it on and they don't really care because they probably can't see all that well to begin with, that's fine. Your toddler, good luck. So, and eye drops are hard enough as it is, but a little bit easier with a kit. So I have had to do this for one of my children, and it's okay. It's not the worst thing in the world, but yeah, so I'd recommend the drops over the ointment. Certainly, erythromycin ointment will cover everything you need. I'd recommend starting with polymyxin trimethoprim eye drops first. They're a little bit less expensive, and they work quite well. Fluoroquinolone and azithromycin eye drops exist. They aren't really first line, so really, unless somebody's getting an allergy to that polymyxin trimethoprim, or if you suspect Pseudomonas, so like an adult who wears contacts, who lets their contact solution get really bad, or put their contacts in like dirty water or something like that, who knows what happens to people. But in that case, you might want to consider Pseudomonas coverage and go straight to the fluoroquinolone eye drop. All right, any questions on ENT stuff? Okay. Moving on to pulmonary. All right, so I'm going to talk about a couple different types of pneumonia here. And most of what we're going to talk about is around community-acquired pneumonia. The rest of the stuff is a little bit debatable as to how you treat it. Most of it, actually, the more severe the infection, usually the easier the treatment therapy gets. So for hospitalated or ventilator acquired or associated pneumonia, you're probably looking at nosocomial pathogens and treating really broad spectrum. With community-acquired pneumonia, it gets a little trickier. And there is a term called HCAP, or healthcare associated pneumonia, which has fallen out of favor. We don't really use it anymore. It was more or less associated with people who, it's kind of like the in-between. So somebody who's not hospital acquired, but maybe they've been in and out of the hospital multiple times over the last year. Maybe they're in a nursing home. But studies have shown that people who are in nursing homes and people who have multiple hospital exposures don't necessarily have higher risks for nosocomial pathogens. It's really like a hospital-acquired pneumonia where somebody's in the hospital for another reason, they get a pneumonia, that's probably a nosocomial pathogen. Or they're on a ventilator, they get a pneumonia, likely ventilator associated. And then we're going to treat for those specific resistant pathogens that live in hospitals like Pseudomonas and MRSA. But HCAP, if you want to treat somebody more aggressively because they have had multiple hospitalizations in the last few months, I'm not going to argue with that. I think that's fair and wise in some cases, but at the same time, it's not necessary to do. And I would avoid treating nursing home patients like hospitalized patients. I mean, yeah, they could be coming from a skilled nursing facility where it's almost like a very stepped-down hospital or a transitional care unit, something like that. But at the same time, it's not necessary really in a lot of cases. So again, look at your patient's history and kind of make that clinical judgment call as you see fit. Okay, common pathogens, strep pneumo, respiratory viruses, of course. Viruses and bacteria can live together, so that's usually, you can diagnose pneumonia on some sort of x-ray or whatever, chest x-ray or maybe more advanced imaging than that. H. influenzae and your atypical pathogens. So Mycoplasma, Chlamydia, Pneumoniae, and Legionella are the three atypicals. Most commonly, Mycoplasma is the one you're going to, well, not see because you don't really culture Mycoplasma, but that's the one that would be most commonly associated with community-acquired pneumonia. Legionella is really odd. It's usually associated with outbreaks like there's the famous case of how it was identified was a bad air conditioner that got moldy and a bunch of people in the same building got sick. Anyway, so cap discharge. What's discharge mean? Oh, so this is what's discharge mean? You're like, you wrote these slides. Discharge means that you're discharging this patient. So this is somebody who's coming into your clinic, your urgent care, your emergency department. They're walking out of there. So this is a walking pneumonia, which is a term I don't like, but I'll use it anyway. Previously healthy with no antibiotics in the past 3 months. So this is the person that's, I don't know. I don't have any comorbid conditions. I'll admit that in front of you guys. So this is me coming in with a pneumonia. Don't use azithromycin on me or I'll be very disappointed in you. Just take that out of your pneumonia vocabulary right now. Every once in a while I still get providers who say, can I use azithromycin? No, you can't. Don't use it for pneumonia as monotherapy. Don't even think about it. Okay, now that we got that out of the way, there will be a test question on that. If you answer azithromycin, you get it wrong. All right. The reason is terrible strep pneumo coverage, and strep pneumo is associated with like 35 to 50% of community-acquired pneumonias. Are you comfortable not treating that for your patients? You shouldn't be. All right. There we go. Now I get off my soapbox for a second. Doxycycline is an okay alternative for somebody as monotherapy who's relatively healthy. The reason why doxycycline loses some ground once you get more comorbidities is because doxy's coverage for strep pneumo is a little bit weaker. Like, I think the Minnesota Department of Health says it's right around 90%, so it's pretty good. It's just not as good as like a third gen cephalosporin, which is about 98% or maybe even higher, basically 100% coverage. So anyway, doxycycline could be good. So why on earth would you even use doxy over some of these other options? I will get there in a second. But usually you're going to go to this comorbidity slide. So even for a healthy patient, don't necessarily think you can't use these. So I put your CAP things into buckets. So you could do doxy if people meet certain criteria. Otherwise, you're probably going to go to a respiratory fluoroquinolone, like levo or moxifloxacin. The other option is to combine azithromycin with either a third or second generation cephalosporin. So I put some examples there, like ceftriaxone or ceftriaxone IV, if you wanted to go. Well, that's a bad example. Hold on. Ceftriaxone would be IV only. So if we're talking about discharge, you can't discharge them on that. So like Ceftonir would be an example of a third-gen cephalosporin. So you can delete that and write that in there. Or you could combine with Augmentin or high-dose amoxicillin. Augmentin, high-dose amoxicillin will cover strep pneumo quite well, and azithromycin will pick up your atypical pathogens. Remember, fluoroquinolones cover atypicals and additional to them, so they're a monotherapy. I have colleagues that like to debate the problems with fluoroquinolones, and they hate them. I'm not in that camp. I think they're okay, especially for this indication. The really nice thing about levofloxacin is it's once a day, and it's a 5-day course. So they've actually studied a high-dose levofloxacin 5-day for community-acquired pneumonia. I'm not trying to pitch it or sell it, but it's pretty darn convenient. And if it were me, I'd roll the dice on the side effects and ask for that, personally. Azithromycin and second, third-gen cephalosporin, maybe a little bit better tolerated. Debatable. It's probably still going to wipe out a lot of GI flora, especially a macrolide like azithromycin will do that substantially more so than a fluoroquinolone. But fluoroquinolones are associated with all kinds of annoying things, like they mess around with blood sugar for diabetic patients. You can see fluctuations, especially more hyperglycemic episodes. They're associated rarely with neuropathies and things like that. Again, I would roll the dice. I don't think there's enough evidence to say that we should stop using them, but again, some of my more crusader colleagues are really against them, but I don't know. We've been using them for years. Again, they're super convenient, and if you want your patient to finish their course and be happy with you because you gave them a once daily 5-day course drug, they're probably going to like that over giving them 2 different drugs with alternating directions, right? So azithromycin usually do like the Z-Pack dosing, which is 500 milligrams one day and 250 milligrams daily for 4 days after that. And then your cephalosporin or your Augmentin is going to be 2 or 3 times a day. So they're taking different things on different schedules. In my opinion, it makes compliance trickier, and I'm always thinking about that with patients, because even really health literate patients who understand, they could be, I mean, even like me, I could forget something like that pretty easily. I don't take medications regularly, so if you got a healthy patient comes in and they don't have a system set up to do that, it's really easy to forget a dose here or there. So if you're taking it once daily, it's 5 days. It simplifies things so much. So anyway, I'll just put that plug in. But certainly you'll hear different opinions on that. Yeah.
What did you say to replace ceftriaxone?
Ceftonir would be an example. Really, any third generation or second generation oral cephalosporin would work in that case. So Ceftonir, Cefixime, Ceftobiprole, those would all be options. As long as it's on that oral slide from the other slide set. Okay, so let's say you're going into the hospital. This person comes in, they don't look so good, you want to admit them at least overnight. It's really similar, and in fact, if they are just barely meeting admission criteria, you can stick to PO therapy. And in fact, you should consider that. Fluoroquinolones have really great bioavailability, so if you're going to stick to that pathway, levofloxacin, you can do the exact same dosing, just admit them to the hospital. Assuming, of course, their GI tract's working right. If they're super nauseous or vomiting from some other cause, or if they have other things going on that make you question the ability of them to absorb the medication, certainly go IV. But definitely PO would be okay for a lot of patients out there. Azithromycin plus third-gen cephalosporin applies. Here we usually do an injection of ceftriaxone just because it's a once daily, covers them for 24 hours. It allows us some time to figure out what we want to do. We don't have to dose something TID or BID while they're inpatient that way. A lot of times what you'll see though is instead of doing the azithromycin IV, they'll do PO azithromycin plus like an IV ceftriaxone. So it's just a convenience aspect. Ceftriaxone is super cheap, so a dose of IV ceftriaxone is not going to break the bank by any means. So we aren't really saving any money, which is why we like to PO the fluoroquinolones if we can, because oral dosage forms are cheaper than IV for the vast majority of products. For ceftriaxone, it's not really true. It's a super common drug, huge demand for it, lots of supply out there. It's very inexpensive. Some other alternatives you can consider. IV Unison could be used in place of the third generation cephalosporin. It's kind of fallen out of favor, and it's like it's at least 4 times a day to dose that intravenously, whereas ceftriaxone is once daily. So unless you have a really good reason not to give ceftriaxone, you probably should just do it. Ertapenem would be the allergy alternative that I would recommend. So if somebody's got a really severe penicillin or cephalosporin allergy, then you could consider carbapenem. But you don't need to go the broadest. So you don't need Pseudomonas coverage for this. So that's why ertapenem would be advantageous over something like imipenem, doripenem, or meropenem. More severe hospital admission. So this is somebody who might be going to the ICU potentially, or they're just sick, but they're still going to med-surg floor. It doesn't really matter. It's just, again, this can be a little bit of a, there used to be, just a background, there used to be a lot of core measures around this. Core measures are things that accrediting bodies look at for hospitals. So the Joint Commission, have you guys heard of the Joint Commission? Some people probably have. If you worked in a hospital, you've probably heard of it. They're an accrediting body for hospitals. So they make sure you follow specific standards. There used to be community-acquired pneumonia core measures where if your patient met ICU criteria, you had to fall into here. If they met standard med-surg, you had to fall into here. They were pretty good, but they've actually taken that core measure away. But a lot of the guidelines still recommend pretty much the same thing, and it makes sense. So anyway, more severe hospital admission, azithromycin plus your third-gen cephalosporin, just give it IV. It's the same thing as the first. Same thing with levofloxacin IV. However, with Levaquin, or if you use moxifloxacin, either one would be fine, IV, plus you're actually adding something else on. The reason is fluoroquinolones, it's basically to double cover strep pneumo. They don't fully trust that if you're really that sick, the fluoroquinolone is going to cover strep pneumo to the extent that the cephalosporin will. And it's true, this coverage is slightly less for, it's like 95, let's say 95% for Levaquin, 100% for a third-gen cephalosporin. So double cover your bases until you know what's going on. If you have a severe beta-lactam allergy, then we can consider imipenem plus Levaquin azithromycin. The reason why we go with imipenem here, again, more sick patient, more broad spectrum coverage. You're picking up Pseudomonas. Whether actually you need that or not is debatable, but it's something that is recommended. If they have a Pseudomonas concern, that would really be getting into that HCAP type presentation. So that's where you have to use your clinical judgment on where they've been and what exposure they've had recently. So if they've been in and out of the hospital multiple times, that's a patient I'd probably be more comfortable with giving Pseudomonas coverage to. And again, there's not really the best evidence to support how long. We used to say like within 60 days if you've been in the hospital you'd get coverage, but that recommendation has kind of fallen out of favor. But if they just got out a week ago, 2 weeks ago, certainly I'd probably consider nosocomial pathogens potentially. Pseudomonas concerns, so we're looking at our Pseudomonas drugs here, Zosyn, Cefepime, imipenem, plus. So this is where things get a little controversial, is Pseudomonas double coverage. And the idea is if you have a really sick person who's in the ICU with Pseudomonas risk, you should double cover Pseudomonas, 2 different drugs. Evidence is really scattered for whether this is actually better for patients or not, and whether it actually makes a difference. And a lot of the evidence says it doesn't. So I don't know if I think it's provider specific at our hospital. We don't really have a policy around it. But I think we do for like ventilator-associated pneumonia, we'll double cover Pseudomonas. So the difference being is if you have somebody coming into the hospital and you're like, well, they might have Pseudomonas concern, you could go with double coverage or not. If they got it from the hospital, then you probably should consider double coverage just to make sure if it's a resistant pathogen, you've got a backup option on board. So that's where these double coverage options come into play. The rare times you'll ever see aminoglycosides used will probably be for double covering Pseudomonas or for resistant Pseudomonal infections.
So you would do, I'm just trying to figure out the order. So you do like one of the top lines plus the Zipro or Levo.
Yep.
Or you could do the aminoglycoside plus the Zipro or scratch that into the.
Yep, that's it. So you're looking at essentially 1 from each line. So 2 antibiotics total is going to be your therapy. So you're picking Zosyn, Cefepime, or imipenem, plus a fluoroquinolone. and then plus or plus an immune glycoside. Azithromycin comes into play. Where it gets confusing is whether you want to cover atypical pathogens in a patient like this. So that would be a presentation where it's like, well, they've had recent hospital exposure. They might have community-acquired pneumonia simple. So we still want to cover atypical pathogens. And remember that none of these cover atypicals except for our fluoroquinolones. So if you're going to go with an aminoglycoside, you have to add on the atypical coverage. Don't stress out about that too much. I know it gets confusing. We don't use aminoglycosides. I would like you to think of aminoglycosides as a reserve therapy for stuff that... Whoa, what happened to my slides here? Oops. What's going on? Aminoglycosides for stuff that this Zosyn, cefepime, imipenem will not cover. So if you're getting resistance to any of those first lines, that's where you'd go. Usually if we're going to double cover, we're going to use a fluoroquinolone as our second option for double coverage. Aminoglycosides, just a thing to remember about them, hard on the kidneys over time. Most people on extended courses will get some kidney damage, usually temporary and reversible, but it's easy to induce acute kidney injury with an aminoglycoside, even if it's dosed correctly. All right, an MRSA concern, of course, you could always add on vancomycin, or if there's an allergy or you had a resistant pathogen, linezolid to the above regimen. So again, that would be more that HCAP type presentation. Somebody, or they have a history of MRSA pneumonia, or they have recent exposure to MRSA, things like that. We'll talk about sepsis too and how that all fits. If they meet certain criteria for sepsis, that's going to fast track you to a more significant antibiotic start than like somebody who's just meeting kind of pneumonia diagnostic criteria. HAP and VAP, pretty straightforward. Somebody's in the hospital, somebody gets a pneumonia because of it. So we're going to treat it broad spectrum, start with vancomycin and Zosyn or vancocefepime. Usually don't have to cover anaerobes for these patients. So vancocefepime, vancozosyn, vanco, imipenem, meropenem, whatever penem you want to pick other than ertapenem would be all acceptable. Usually 7 days. Some patients, again, our ICU patients, are probably going to double cover them right off the bat. COPD exacerbations are a little bit tricky. They aren't really thought of as bacterial exclusively. They can be viral, but there's been a lot of studies, and how you approach them varies on what you read. But basically, if a patient has limited risk factors, treat it sort of like a limited version of a community-acquired pneumonia. So you can actually use azithromycin monotherapy for a COPD exacerbation, or you could go to a single cephalosporin or doxycycline. So any one of those would be fine. Bactrim also has decent strep pneumo coverage and could be used. It doesn't cover atypical pathogens, though. Again, it doesn't totally make sense why we treat COPD exacerbations the way we do, but that's just the way it is. Think about it like a step-down cap, and hopefully that makes some sense to you. These are some criteria where you might basically want to treat it like a more severe lower respiratory tract infection, so using a respiratory fluoroquinolone. Augmentin by itself has been shown to work well for severe COPD exacerbation, so whether or not you need to go with a full fluoroquinolone, maybe you would reserve that if your patient's allergic to penicillins. And then inpatient therapy is similar. Pseudomonas risk would be similar to what we just talked about. So COPD exacerbations are kind of odd. We'll talk about those a little bit more when we talk about respiratory and COPD itself in coming weeks. Don't worry about that. I don't think I ask any questions on that for this exam, so you can cross that one off for now. All right, endocarditis, very quickly. Endocarditis is very complicated, and it's something that an ID specialist should be managing. So what it is, infection of the inner lining of the heart. We'll cover this slide and then these slides and then take a quick break, by the way. So usually it's associated with bacteria entering the bloodstream. So some sort of a bacteremia going on, and the bacteria find a spot in the heart where they like. They end up kind of developing a vegetation, and you get valve interference there. High-risk people, so the people we usually see these, poor oral hygiene and post-dental procedures. So that's the most common places endocarditis pathogens enter, are from the mouth. The other ones are IV drug users, especially if you have a young person who has infectious symptoms. They come in looking septic, blood cultures are positive, likely going to need endocarditis workup. It's really common. Think about stuff that's in needles, dirty needles, people licking needles and injecting. It's really not that far-fetched, right? Okay, nice picture. So what are we looking at for bacteria? Strep viridans and Staph aureus are the two most common presentations. Less than 10% are Enterococcus, which is a GI bug. Coag-negative staph is something that grows on the skin. It's usually thought of as a contaminant, but it can be pathogenic in endocarditis people. So sometimes when we do blood cultures on people to see if they have some sort of bacteremia, we always draw 2 bottles, right? So we want to make sure that if one's growing something, the other one is too. And a lot of times what we'll see is one grows coag-negative staph and the other one doesn't. That means that one bottle at some point got a little bit of skin staph in it, either from a contaminated sample draw, somebody touched it accidentally, it brushed up against something, and therefore it ended up getting contaminated. So if we see 1 out of 2 coag-negative staph for blood cultures, we know that's probably a contamination. In an endocarditis patient, you might see 2 out of 2 coag-negative staph, and that's actually the pathogen. It's a little bit more unusual, but it is possible. And then you have a group of odd gram-negatives that affect endocarditis patients. Again, this gets into the weeds a little bit, more complicated, but I listed them there for you. I won't test you on the HACCP group or anything like that. Endocarditis treatment is long, kind of like osteomyelitis, so 4 to 6 weeks. Prosthetic valves require a longer treatment, usually 6 weeks. Blood culture generally positive in patients. So again, you probably have some sort of bacteremia going on at the same time. Empiric therapy is somewhat basic. We're focusing on staph, strep, and enterococcus, so mostly on their gram-positives. Ceftriaxone, vancomycin are going to be the 2 common ones you're probably going to give somebody. Generally speaking, we can't rule out MRSA right away, so until we can get a blood culture that's giving us something, we're probably going to be on vancomycin. If somebody has a prosthetic valve, the vegetal growth of the bacteria tends to be thicker, and rifampin is you might remember this briefly from the, I don't know, we haven't talked about that yet, but we're talking about that for tuberculosis. So it's a tuberculosis drug. It's got some odd synergies, and this is an example of one where it actually helps tissue penetration, so it's called biofilm penetration. When you get thick vegetation growing on a valve that's prosthetic, it helps get the bacteria or the antibiotic in further into that growth. But that's really one of the only times we use that. So rifampin for prosthetic valves. Otherwise, for the most part, we're going to follow these straightforward guidelines. I know it looks a little complicated, but vancomycin is almost always recommended. You would basically start with vanco and probably ceftriaxone. Again, do your blood cultures, and you'd probably move and narrow. So depending on, let's say you get an MRSA coming back, you'd probably just do vancomycin therapy by itself. You don't usually have to do gentamicin. Sometimes people might add a low dose aminoglycoside like gentamicin for synergy. It's got good synergy with vancomycin, and you can do it. It's got proven synergy at a much lower dose than you would require if it was like a monotherapy agent you're trying to use by itself. So you can get by with less side effects with it, but it's not super common. Enterococcus, Unison covers Enterococcus, while Vanco also covers Enterococcus. So again, think about enterocarditis. Basically, right off the get-go, you're going to do Vanco, probably ceftriaxone, and then narrow from there. That's really all I want you to know about that. Again, it's complicated. It's a long treatment course. You have patient compliance things to consider, especially with an IV drug user. So making sure that you're getting an ID consult on board is probably going to be beneficial. So let's take a quick break. All right. Central nervous system infections are similar to endocarditis in that they're fairly serious. There's a lot of management things that go on, so I'm not going to require you know a whole lot. And they're kind of complicated, but they're actually not that bad. So here's some interesting stuff. Just you do a lumbar puncture. CSF findings can tell you whether or not you're likely to see bacteria in there. You can do a CSF gram stain too to figure out what you got going on. But these are generally the CSF findings you'd look at for a fluid if there is bacteria in it. Usually glucose is low, protein's high. Remember that the bacteria must be in there eating glucose and making proteins of some kind, which is why the simple way to look at it. But this is an absolute, so we always do blood cultures and we always culture the CSF as well. Bacterial meningitis, even when you treat it correctly, is fatal in high amounts of cases. So we always want to treat it very aggressively right away. So as soon as you get that lumbar puncture and get your fluid, make sure you get your antibiotics started right away. True bacterial meningitis is actually quite rare, but it is not a good thing to have. So different age groups have different bacterial pathogens, and I don't want you to memorize this. Don't think about it too hard, other than that you can look at the treatment choices and hopefully make sense of this. The idea is that most patients we're going to see probably fall into this 2 to 50 year age group or the 50 plus year, right? Unless you do peds, which is a little bit different of a population. But you don't change the antimicrobial therapy all that much. So usually we're looking at vancomycin and ceftriaxone for the vast majority of patients out there that are anywhere actually from 1 month old to 50 years. The only thing that gets different in the elderly patients is you add on ampicillin. The reason being is ampicillin covers listeria really well, where the other drugs don't cover it quite as well. So that's the only difference with our elderly patients. That's really all I want you to know is that age cutoff. So know that that's our kind of baseline that we test for meningitis. We're going to do Vanco plus 3rd gen, aka ceftriaxone for most patients. Nice thing about meningitis, well, not the nice thing, but one of the things about meningitis is you usually don't see Pseudomonas or any more resistant gram-negative pathogens. It's possible, but you would hopefully see that in a CSF culture. So the idea is that you get your cerebral spinal fluid cultured right away. It comes back saying there's gram-positive cocci and chains or whatever it might be, and that should be able to lead you down the pathway towards whether your antibiotic therapy is appropriate or not. But then you actually, hopefully the culture will grow out something, but usually you're going to keep people on this. The reason is it's a little bit overkill if you think about it. Neisseria and strep pneumo probably would both be covered by a 3rd generation cephalosporin on its own, but Vanco is a little bit of a double coverage aspect. Covers Neisseria really well, and you pretty much guarantee that both things are getting covered by both drugs at that point. Again, very serious infection, so we don't really want to take any chances with it, but on the off 2% chance that it fails, that we have something else as a backup there. And this is a little bit more simple slide, so your organisms and your therapy here. And some alternatives in case you're curious about like allergics patients or stuff like that. There are options out there. Hopefully you'll never have to prescribe somebody chloramphenicol. It's a super odd one. Okay, Helicobacter pylori is the primary culprit of some types of peptic ulcer disease. And so the way we do this is you test for IgG to see if the patient's had an immune exposure to H. pylori, and if it comes back positive, you assume that they've had an infection recently or they have an active infection. Where it gets really confusing is if you have somebody, I actually had this happen to me a couple days ago, where I had somebody whose IgG came back positive, but they had been treated for H. pylori 3 months ago, I think. So still, their body still could very well have antibodies built up. That doesn't mean they have an infection. So when you get these recurrent peptic ulcer diseases, that's where you might have to be a little bit careful on not totally overloading the patient. You can always send them in for, I think, how do they confirm eradication? Do they scope the person and take a sample? I'm not exactly sure how that works. But you can do that too if it was, again, a repeat case. But that's just my words of wisdom there. But anyway, if you have somebody coming in, they test positive for IgG, and you're looking at likely a treatment course, especially if it's the first time for them. So standard triple therapy is the common one we use. It's the most convenient regimen out there. You're doing 1 gram of amoxicillin twice a day, clarithromycin 500 BID. And by the way, there's only one dose I'm going to ask you to know for the exam, and that's STDs, which we're coming up on. You don't have to know any other doses for the test. Clarithromycin 500 BID, and then you do a proton pump inhibitor, which are drugs like Prilosec, Nexium, etc. Proton pump inhibitors are stomach acid suppressants, and that's twice a day for 14 days. If you have a penicillin allergy, you can substitute metronidazole for the amoxicillin. The idea is you're covering Helicobacter can be a little bit difficult to treat, and even with either one of these therapies, whether it's triple or quadruple, it's about 20% chance of first-time failure. So I don't know, it's something to do with maybe where the bacteria is located, not being able to keep bacteria in the stomach or the upper GI tract that long, or sorry, not bacteria, antibiotic. But I'm not entirely sure why that is. That just seems to be the case where it fails no matter what you do in about 20% of patients. If triple therapy fails, try quadruple. And then there are some levofloxacin-based therapies after that, which I won't get into. But quadruple therapy is really annoying because you're taking tetracycline and the PP, and they actually recommend bismuth subsolate, which is Pepto-Bismol. And that actually has some topical antimicrobial properties as well. But you have to take tetracycline and the Pepto 4 times a day, in addition to the PPI twice a day and the metronidazole twice a day. So you're taking different things on different schedules. Again, the standard triple therapy is likely similar in efficacy to quadruple therapy. It's just easier for patients to do. This is just an algorithm that shows you how you might make that decision. All right, intra-abdominal infections. I just put up a copy and paste of a table here, as you can see, from the IDSA guidelines. So the thing to remember about intra-abdominal therapy, it's a lot less complicated than all these drugs up here, but I think this gives you a picture for where you can go. And it might be a good way to think about studying what covers gram-negative bacteria and what covers anaerobe bacteria, because that's usually what we're looking at for most community-acquired intra-abdominal infections. So think about these as appendicitis, diverticulitis, and those can vary in severity, right? You can have a appendicitis or a ruptured appendix, right? That's going to depend on, that's going to maybe make your treatment a little bit differently. So that's where they've differentiated here on IDSA. So for mild to moderate, this is somebody with a abscessed appendicitis, maybe a perforated appendicitis, but not like a really, they don't look sick enough to be considered septic. That'd be kind of the patient I'd put in this group. Monotherapy is fine. So think about drugs that cover both good gram-negative coverage and Bacteroides coverage. So that's going to be cefoxitin, ertapenem's on there. Moxifloxacin would cover that too. Ignore ticarcillin because we just don't use it, and tigecycline. You would never use tigecycline for this, ever. I don't know why it's even in the guidelines. I suppose some places in the world might use it, but it's just a really broad spectrum drug that's got a lot of issues with it, and we only use it if we absolutely have to, and this would not be the case. The other things you can do, which is much more common than using a monotherapy actually, is an easy combination with metronidazole. So I always think of metronidazole given IV as like a Bacteroides agent. That's really what it's covering. And then we're adding something else on that's got good gram-negative coverage. So our most common thing is ceftriaxone plus metronidazole. That's going to cover the vast majority of your mild to moderate to severity community-acquired intra-abdominal infections. Now, you have other options on here. Certainly, you could do other cephalosporins. Ciprofloxacin and metronidazole, ciproflagyl, is a really common combo that people used to use. The problem with Cipro is its E. coli coverage is weakening, and it's gotten worse over the last decade or so. So ceftriaxone covers E. coli like 98%. Cipro, 79, 82%, somewhere in there, depending on what you look at. Not great. So that's why we recommend that. The nice thing is that ciproflagyl's got a good ring to it, right? It's easy to say. So we're like, oh, we'll just do ciproflagyl. It's easy to remember. Wrong. It's not the best choice right now. I would never, like, if you prescribed it, I would never, well, actually, I might ask you to change it now. We've kind of changed our mind on that. It used to be, like, a couple of years ago, I probably wouldn't have cared. We're getting to the point where the Cipro's resistance to E. coli just keeps kind of ticking down to the point where it's not as favorable anymore. Now, switching gears from our mild to moderate column to our high risk column, this is going to be just a big broad spectrum gun. So think about something that covers your anaerobes and also covers your gram-negatives broad spectrumly. Is that a word? I just made something up. Anyway, Primaxin, Penems, Zosyn, or combine cefepime with metronidazole. So that's pretty much going to be what you're going to do. Other than that, that's about it. So my word of advice to anybody who wants to go into urgent care or emergency medicine is if you're ever going to get somebody going to GI surgery for something and you're thinking about, oh, I'm going to be nice and start antibiotics now, wait for the surgeon because they like to do their own thing, and even if it's like a mild to moderate, they might want Zosyn. And I've argued with some people on that. They just don't really care anymore. It's not worth arguing with a surgeon. And you could probably debate whether it's not, well, they're older or whatever it might be, or physiologic disturbance. Whose definition is that? You know, the guidelines do go through some of that if you want to look at them more in depth. But ultimately, I'd recommend waiting for the surgeon because I've had multiple cases where we've decided on something with the urgent care, or the ED provider, and then surgeons come in and say, "No, I want Zosyn." Okay, sorry. Sorry, I was trying to avoid C. diff and extra cost and whatever, but I failed. My bad. Treatment of biliary infections. So this is going to be very similar, except you're losing some of your need for Bacteroides coverage. It's just not as common of a pathogen. Usually you're looking at E. coli or other GI gram-negatives being the most common things. You know, the more acute you get, you're going to add coverage to do that. But basically you can do a pretty simple cephalosporin. Even cefazolin is fine for this. And then you're adding on broad spectrum stuff the more severe it gets. So it's pretty straightforward. Just that's the only real difference between the biliary versus the extrabiliary infections. Any questions on intra-abdominal? It's a little bit complicated.
What were the two that you said were the
Metronidazole, yeah. So metronidazole is going to be always added on to your regimen unless it covers anaerobes by itself. All right, C. diff. So C. diff is why, well, one of the reasons why we care so much about the antibiotics we're giving our patients, and we want to limit antibiotic exposure already. It's a very well-studied direct correlation between increased antibiotic use and increased C. diff rates. So we actually have two infectious disease specialist pharmacists that review, basically they look at any patient that doesn't have an active ID consult and they are inpatient and getting antibiotics. Like if our hospitalist group is prescribing antibiotics, they'll follow those patients. And what they do is they try and get people to stop antibiotics that aren't necessary, narrow the coverage. So if they're on really broad spectrum and they don't need to be, bring that down a notch. And making sure that people are being followed up on. Sometimes you might have somebody who is in the hospital for 7 days. They're getting, ceftriaxone, 7-day hits. Maybe they get transferred to a rehab unit or something, or a step-down unit out of the ICU. They're out of your care at that point. You've given plan to somebody. That person continues the antibiotics. They get going. Now it's 10, 12 days. That's where our people can kind of step in. It's nice to have somebody watching over the shoulder a little bit. And they've actually proven that they can reduce C. diff rates. So we actually got our hospital got a national award for that because we implemented this stewardship program and actually reduced our C. diff rates dramatically. And we've continued to see a reduction every time we've expanded that service. So it's a pretty cool thing. But that's just, when I talk about antibiotic stewardship and stuff like that, there's cost associated with that and great things like that. But this is really a big patient impact factor, I think, because C. diff will increase your hospital stay. It is hard to get rid of in some cases. Some people have recurring episodes where they're on really complicated oral regimens to get rid of it, long tapers and high doses, and it just gets challenging. And it's, of course, really uncomfortable to have multiple episodes of diarrhea a day going on for weeks. So it's, to the benefit of our patients and everyone in society to make sure that we're stopping antibiotics as soon as possible, if it's necessary. Now the question comes if somebody's in the ICU and they're septic and really sick and on really broad spectrum antibiotics. If it's indicated and they get C. diff, that's kind of just a casualty that happens every once in a while. We still want to try and save their life. So it's not like we're going to withdraw super broad spectrum antibiotics because of their C. diff. Right? We're going to try and balance that out a little bit. But if we can narrow it down or maybe stop one of the agents, not do dual therapy but monotherapy, it might help a little bit. So basically what happens is you get wiping out of certain GI flora, your GI flora gets out of balance, and then you get an overgrowth of Clostridium and some sort of a colitis on top of that. So we're treating people with, I put some of the common ones up here, but really any antibiotics, these are common ones that are less likely to cause C. diff. Most antibiotics actually have some sort of a loose association with causing C. diff. You'd think that ones that cause target anaerobes would be higher, and you'd be right. So like clindamycin, augmentin, zosyn, primaxin, etc., a lot more likely to cause C. diff statistically, but still any antibiotic can really put people at risk for it. And just remember, think about it, that anaerobic coverage wipes out more GI flora than something that doesn't have strong anaerobic coverage. So that's why you're at higher risk. When I was at the VA, I did a bunch of rotations there. They actually don't use clindamycin at all because it got some really bad flack for C. diff rates, and they don't use it at all. We do, so I don't know. Some places might have different regulations on that. All right, so treatment regimen, vancomycin PO. So one important thing that I said in the last set that I'll repeat here, you cannot use vancomycin PO for systemic indications. Vancomycin PO is for C. diff and C. diff only. You do absorb probably a small amount of it systemically, but it's negligible. In fact, it's not going to cause side effects really. That's probably the one advantage of treating C. diff is there's not a lot of side effects to the medications we give. They're already having profuse diarrhea, so they aren't really going to get any systemic exposure to the drugs. It's not like we have to worry about kidney failure or anything like that. It's staying in the GI tract. Think about it as a topical therapy. So it's getting into the GI tract, getting to the site of action. It's not getting out. It's not getting absorbed into the bloodstream or anything like that. So we give vancomycin 4 times a day. There used to be recommendations that you start with oral metronidazole, and that has fallen out of favor with the most recent C. diff update from IDSA that just came out. So we actually start people on vancomycin right away, whether it's a severe or mild episode, depending on how many bowel movements they're having a day, whether it's bloody diarrhea, etc. Doesn't matter anymore. We just start with vanco straight up. It's just been proven to be more effective right off the bat than metronidazole was. So 4 times a day, not the most convenient dosing, but that's the way it is. For the initial episode, severe or relapse, we're still using vancomycin. So the way we do it is we'll start with so the dosing, just to give you an idea, it's 125 milligrams 4 times a day. If they fail that, we're probably going to increase that to 250 or 500 milligrams 4 times a day. If they fail that, you could consider trying an extended duration and then a taper. There's taper schedules out there. So basically you have somebody on weeks of vanco and then you slowly taper their dose over like months. So sometimes these people are on these really prolonged vanco tapers with complicated C. diff type infections. So it can be challenging to manage, but there are guidelines out there. I'm just not going to get into them because it gets complicated. Fidaxomicin is a newer drug that is for vancomycin resistant cases. It could be an alternative. Maybe you tried a vanco taper, still not getting good efficacy. Fidaxomicin, it's more expensive than vancomycin orally is, but it's an option. IV metronidazole for severe inpatient cases, you could do like a week's course of that, and the idea is it does still penetrate the GI tract when you give it IV, and it might be synergistic with vancomycin, but we usually don't use it orally anymore for C. diff. There are some interesting other things that you could try for C. diff. You might think probiotics would be helpful. You'd be wrong. They've been studied. They aren't helpful. Fecal transplant. So this is something that actually was pioneered at the medical school in Duluth. And they actually will take the feces of usually like a family member. So somebody donates a sample, and they somehow put it into pill form, or I don't know exactly what they do with it, or they put somebody under sedation and put a tube down their throat. I'm not sure. Either way, it doesn't sound pleasant, but it actually has pretty good evidence with it. It's sort of a last-ditch effort. Obviously, it's a little bit, well, invasive is an argument. I don't know if that's the correct word to use here, but it's not a pleasant experience or pleasant to think about it, but it is something that actually has pretty good evidence behind it. So if you're failing all these other things, you might be a candidate for that.
So
yeah.
probiotics don't like help cure it, but do they help prevent it?
No. There's no evidence that they do. Yeah. It's not going to hurt a patient to take them. If it gives a patient peace of mind, go for it. But there's no evidence that it prevents C. diff. Now, does it prevent GI-related upset with antibiotic use? That's debatable. I don't think that's as well studied. I personally don't think from what I've read it does, but again, certainly it's not going to hurt the patient to take probiotics, whether it be like an oral capsule or like yogurt or more like a food source. Other enteric pathogens, if you have somebody with infectious diarrhea and you do a stool culture, these are some of the things you'll see come up. Salmonella, food poisoning. It's usually self-limiting, and we probably are going to treat it if it's severe, so 9 or more stools per day, and if they have a fever. You could consider treating it if it's a little less severe than that. We treat most salmonella patients. Cipro is the drug of choice for salmonella. Shigella is another one, similar. We actually treat all Shigella cases regardless of presentation, so that's fluoroquinolones like Cipro work well for that as well. Campylobacter is a self-limiting one, and you'd really only treat it if the patient had pretty bloody diarrhea, profuse bloody diarrhea, or had to be hospitalized due to like dehydration or something severe like that. But otherwise, you let it resolve on its own. By the time you give these antibiotics and they've already expressed significant symptoms, it's just not going to decrease their symptom length, so there's not really any point in doing it. But macrolides, fluoroquinolones like Cipro, clindamycin, tetracyclines, they all work for this. So if you're thinking about this, Cipro works for everything so far, right? So it's a good one to remember. And if you've ever gone and traveled somewhere, maybe people have gotten prescribed short courses of Cipro to take in case you get traveler's diarrhea, and that's because of this, right? E. coli is a little bit tricky. So E. coli can cause kind of a standard traveler's diarrhea presentation, and there's strains of E. coli that are fine to treat with antibiotics. The tricky thing are these enterohemorrhagic strains. So you might hear of EC or EAGC or the 0157 isolates, or you might hear Shiga toxin producing. That's always confusing for people because people hear Shiga toxin and they think Shigella. Shiga toxin actually is enterohemorrhagic E. coli, and that's the name of the toxin it produces. The problem with this is if you give antibiotics to somebody with this, you're going to lyse bacterial cells and increase the toxin load in their GI tract, causing more problems and put them at risk for hemolytic uremic syndrome. which can be problematic for the kidneys. So we want to make sure that if we're testing this, test your stool samples to make sure, try and figure out what you're treating if you think it's infectious. And then if you ever get one of these strains come up, make sure you aren't treating with antibiotics. That's probably the big take-home point. Otherwise, Cipro is a good one to remember for these enteric pathogens, the enterohemorrhagic strains we'd want to avoid. And that's basically supportive care. So replace fluids, advanced diet is they can tolerate it, but you kind of want to wait for it to finish its course. If it's really bad, you might need to hospitalize the patient, but that'd be kind of rare. All right, GU. Okay, UTIs. UTIs are a bit of a mixed bag. Usually we're going to treat them if they present with standard symptoms, so dysuria, urgency, frequency. Flank pain fever is usually indicative of pyelonephritis and is treated a little bit differently and more aggressively. So think about them as two separate things. We'll talk about simple UTIs and pyelonephritis. Asymptomatic bacteriuria is generally not treated. So if somebody has no urinary, this happens a lot where people have no urinary symptoms, but you might be thinking that, so you get a urine analysis on them. It looks like they might have some bacteria. You culture it, it comes back growing something, and you call the patient. They're like, no, I'm fine. Like, well, what do you do in that situation? Guidelines would say nothing. So some people might just be colonized with certain bacteria. The exceptions are pregnant patients, people undergoing traumatic urologic interventions, and just deemed high risk. So if you have somebody who's immunocompromised or whatever you might consider high risk, you could prescribe it based on your clinical judgment. Contamination, colonization, and infection are all things to consider. People with catheters long-term will likely grow something in their urine. Whether it's an infection or not is difficult to say because they might not have traditional symptoms. So looking at those ancillary things like fever, white count, stuff like that to see, because they're probably going to have something growing, especially if it's like a quad or a paraplegic patient who's had a indwelling catheter for quite a while. And E. coli. E. coli is the primary bug here. UTIs almost always grow E. coli. There's a couple other things you might see pop up. Klebsiella and Proteus are not uncommon. Staph saprophyticus is gram-positive that might pop up too. All of these things are basically treated with the same set of antibiotics. There's very little difference, so that's the nice thing. Empirically, we're basically covering the same stuff. 4 basic options for treating a UTI empirically: nitrofurantoin, Bactrim, cephalexin, and Cipro. I highlighted nitrofurantoin and cephalexin because they have the best E. coli coverage out of the 4. Bactrim, I would never prescribe empirically. Again, you got like a 1 in 5 chance of resistance there. Cipro, still pretty similar to Bactrim, actually. The nice thing about Bactrim and Cipro is that they're 3-day courses. So if you had urine culture data to work with, you might consider doing that. But if you have nothing, don't prescribe them right away. I prefer Macrobid for healthy patients. So the perfect patient for Macrobid is a healthy female who has a UTI. 5 days, twice a day. It's relatively convenient. And the people these wouldn't work in would be somebody with kidney failure. So Macrobid really has to get into the bladder to work. So if somebody's kidneys aren't working well, it's not going to concentrate in the urine like it should. Also, it can cause some systemic effects when it gets accumulated in the bloodstream, which is really rare for a healthy patient. They'll just excrete it. Macrobid, one of the nice things is it virtually does nothing. It just goes, well, other than get into the urine, it doesn't do a whole lot. Very few side effects with it. And cephalexin, it's a longer course. It's a 7-day course versus a 5-day or 3-day course. That's its disadvantage. Otherwise, it does cover E. coli quite well. It's like 90-95% coverage. Follow your cultures, get a urine culture, adjust. One of the things I keep in my back pocket are 2nd and 3rd generation cephalosporins for more advanced cases. That's something. Doxycycline is something that could be used too, that gets into the urine. It's kind of an odd one that might work in pathogens you don't have coverage with the traditional things. Pregnancy. Macrobid is a little bit debatable in 1st trimester pregnancy, but generally okay. Cephalexin is good for all trimesters, so we usually use a cephalosporin for pregnant patients exclusively. Complicated UTIs usually would be a pregnant patient, a male patient, chronic catheterizations, those types of things. The reason males are a little bit different is it's difficult diagnostically to rule out prostatitis at the same time as a simple UTI. And unfortunately, drugs like nitrofurantoin don't really do anything to the prostate gland. So that would be a person with a complicated UTI. We usually rule out nitrofurantoin for the most part, just because it's a little bit more advanced anatomy, whether they're male or chronic cath or whatever. But usually you're looking at a longer treatment course and higher doses as well. So. All right, for kidney infections, pyelonephritis, very similar pathogens to UTI, same thing, but it's further up the urinary tract, right? So remember, macrobid is not a friend here. It just really gets into the bladder. We don't use it anywhere else. Beta-lactams have really poor kidney penetration, but they can be used. You just have to use them at much longer courses. Fluoroquinolones actually have really good kidney penetration, and they become first line, despite the fact that their E. coli coverage isn't that great. What we'll do a lot of times for somebody leaving with pyelonephritis is we'll give them an IV or IM dose of ceftriaxone. That assures they're getting a very active form of a cephalosporin that if you give it at IV or IM concentrations, it should penetrate the kidneys quite well, even though they don't have the greatest penetration to begin with. And then like 5 to 7 days of Cipro or levofloxacin. That's the common way we'll start a pyelonephritis patient. You could certainly use other drugs too, Bactrim, Cephalexin, Ceftriaxone. Duration extends to 14 days, and you have to be careful with your culture data, right? So same thing applies with Bactrim here, 20% resistance. Just be careful using it right off the bat. But we use Cipro, so there's that to think about. We up the dosing. So for a simple UTI, on the previous slide, Cephalexin is BID. More severe infection, more frequent dosing, we up it to QID. And again, I'm not testing on doses or frequency, so don't worry about that. Ceftriaxone is twice daily. That's a second generation cephalosporin. That's something we do in place of Cipro sometimes. Some people just, really don't like fluoroquinolones, so they'll give an IM shot of ceftriaxone and discharge them on a couple weeks of ceftriaxone, so 14-day course or a 10-day course, something like that. That's fine to do too. It just depends on your comfort level. Okay. Pregnancy is similar, just extended course. All right, STDs. What everybody's been waiting for all day, right? This is a picture I found online. I don't know if this is real or somebody made it up, but there was a lot of stuff like that about various wars and GIs going off and getting infections. So anyway, kind of funny. Bacterial STDs. So these are the only 2 doses I want you to know for the exam, and I just think it's important because no matter what practice you work in, you'll probably see this pop up here and there. I think it's important just to know them. Chlamydia is treated with azithromycin, 1 gram PO for 1 dose. Doxycycline is an alternative to chlamydia. It's a 10-day, 100 milligram BID course for 7 days. I don't want you to know the doxycycline dose because I want you to think about prescribing azithromycin. The reason why you prescribe doxycycline is not clear to me. Some provider, so there is actually some evidence that the doxy course is slightly more effective than the azithromycin one-time dose. But think about our patient populations. Though these people might not be compliant, they might not fill a prescription, a one-time dose is much more likely to get, it's got better chances from the get-go, right, than finishing a 7-day course of doxy. So azithromycin's convenience trumps doxycycline's slightly higher efficacy rates in my book. And the guidelines will say the same thing. Gonorrhea is treated with ceftriaxone. It's a lower dose. So usually with ceftriaxone, we're treating 1 or 2 grams for like a respiratory infection, for example. But this we do 250 milligrams IM. Plus, the guidelines recommend adding azithromycin. So even if you just have gonorrhea that you tested for, you would still treat with both. So whenever you suspect a bacterial STD, treat for both. That's the moral of the story here. Always give ceftriaxone and azithromycin. Then you're covered for both. And if they happen to just grow chlamydia, well, the ceftriaxone 1 dose isn't going to hurt them. Gonorrhea has growing resistance in the community. In fact, ceftriaxone's not as good as it used to be. There are some other options. So there is a 2 gram azithromycin one-time dose that some people will try doing. It's not as effective. There's a cefixime dose that people have studied, not as effective. If you try any of those other options, like if you don't have access to the IM ceftriaxone, but you can do PO, or for whatever reason your patient's going to freak out if you stick them with the needle, and they refuse, but they'll take the oral regimen, they have to get retested after I think it's a week or so, you retest them. So whether your patient's going to come in for retesting or not, again, debatable. So that's why we prefer that IM shot of ceftriaxone. Trichomoniasis, not going to test you on these, just the bold doses. That's the only thing that I'll test you on for doses. Trichomoniasis, parasite, metronidazole, 2 gram dose times 1 is effective for removing that. Bacterial vaginosis, not necessarily an STD, but if you did have something growing on a culture or You saw clue cells on a vaginal wet prep. That would be indicative of possible bacterial vaginosis. If the patient's symptomatic and you see some of that diagnostic stuff, metronidazole times 7 days as an oral course is effective for that. Otherwise, Metrogel is a topical metronidazole presentation that works just as fine too. So for like a pregnant patient, that's a great option because it's really not going to absorb systemically. Syphilis is more complicated, and I don't care that you know all the different types of syphilis out there. There's primary, secondary, and late stage. So syphilis initially is a pretty limited symptomatic presentation. You get about a 2 to 3 week incubation period. People will notice what's called a chancre, which is kind of like I didn't put a picture of a chancre on here to spare you guys that, but it's like a red ulceration, kind of looks like a cold sore almost, and apparently it's painless from what people tell me. Don't personally have experience with it, so I don't know for sure, but it's certainly in the pictures that like my I don't know, my professors in school like to tease us with. It doesn't look painless to me. But anyway, bacteria is usually pretty widely disseminated at that point, so topical things won't work. You have to use something systemic. Secondary syphilis, weeks to months, nickel and dime rash like you see on these hands here. And late stage involves cardiovascular and neurosyphilis, can actually be really nasty. And actually can have, even if you cure the infection, can have lifelong implications to how damaging it can be. Al Capone died of syphilis, in case you guys didn't know that. Oh, this is another fun thing I found on the internet. Apparently some company makes little cute bacterias that are stuffed, and this is a Treponema pallidum. It's a little... Oh, really? Oh, yeah. It's kind of weird. I don't know. It is kind of cute. My kids would like that. They would have no idea what it is, but they'd like it. All right. Treatment. So, yeah, that's a perfect Christmas gift. Yay. Here's a box of STDs. All right, so treatment's basically, I already talked about this, penicillin. Use double the dose you'd use in strep throat, so it's 2.4 million units, but it's a one-time dose for early treatment. For latent or unknown duration, you just repeat it every week for 3 weeks, so you do end up 3 total IM shots of it, or sequences of it, I should say. Alternatives. Alternatives are frowned upon. You wouldn't use them unless you really had no other choice, and generally speaking, medical community is in agreement that you don't use alternatives for syphilis. You desensitize people to penicillin and use penicillin. So that's what you do. The thing about syphilis is it takes a long time for it to do anything really bad. So if you catch it early, you have time to desensitize somebody. So it's not like you're in a rush to get them this, oh, let's do doxy because we can't do penicillin. No, desensitize them to penicillin. The basic concept behind a desensitization protocol, I think I talked about before, but you start somebody and you kind of give them doses in a ramp-up form over like a few hours. There's different protocols out there, like 6-10 hours is pretty common. And then you keep some epinephrine on hand, like an EpiPen style Benadryl, keep it ready to go in case they have an anaphylaxis. But it is effective at limiting their overall reaction. And then they go through the desensitization protocol, okay, you can start the full dose after that. Neurosyphilis, same treatment. We use IV penicillin, and we do it at high doses for 2 weeks straight. So this is a hospitalization. IV penicillin's dosed like 4 or 6 times a day. It's not the most convenient thing, but it is the recommended treatment for neurosyphilis. Neurosyphilis is not common. Throw that out there. Although syphilis itself is actually getting more common. I didn't used to see it pop up on our culture follow-ups a lot, but I'm seeing it much more so the last couple of years than I did like the first couple of years of my career. Okay, sepsis. So sepsis itself is not necessarily one infection, right? You guys have probably talked about sepsis to some degree. Bacteremias are not sepsis either, but they can go hand in hand. So sepsis is a systemic inflammatory response that has some sort of infection behind it. And there's biomarkers we can look at for sepsis. I'll show you some of those in a second. But bacteremias can certainly cause sepsis, but usually a pneumonia can cause sepsis without a bacteremia. Urinary tract infection, pyelonephritis can cause septic-like symptoms, urosepsis. And then like a really bad cellulitis or diabetic foot ulcer could also cause sepsis. So really think about it. Your body is reacting to this pathogen. It's trying to kill it. It ends up ramping up all sorts of prostaglandins and things like that, and you get a vasorelaxation effect throughout your body. So vasodilation, and you end up dropping your blood pressure, you get tachycardic, and that's where you start to see septic pictures, in addition to elevated white counts and fevers and things like that. Sepsis is really severe, can be really severe, so you want to get on top of it as soon as you can. And there's really good evidence that says the sooner you start antibiotics, the better outcomes the patient has. So that's very well correlated. So we actually have a lot of protocols in our hospital around sepsis care. And if somebody's septic, we do a follow-up to make sure that they got antibiotics within a certain time frame. Again, these are the criteria. So SIRS is systemic inflammatory response. Sepsis is two SIRS criteria plus some sort of confirmed or suspected infection. Severe sepsis is sepsis plus you have end organ damage. And septic shock is somebody with hypotension that's not really responding to fluid boluses. It's not responding to vasopressors, which we'll talk about during cards and some other places too. So we get really concerned is with these two, obviously. The more severe it is, the more we need to start that fast. But you always want to make sure you get your blood cultures first before you start your antibiotics. So blood cultures, antibiotics, manage the symptoms that way, and hopefully your patient does okay. I just threw that in there just for reference. So again, any of these infections we talked about could technically lead to sepsis picture. And sepsis automatically indicates advanced therapy, especially if you don't know what you're treating. Tuberculosis. I am not going to test you on tuberculosis as far as anything complicated. What I would like you to be able to recognize is these 4 drugs and know that they are used for tuberculosis. That's it. They're odd drugs. The only and I'm not going to ask you anything about rifampin outside of TB, so don't worry about the biofilm penetration thing. Keep that in the back of your mind if you're interested in it, but I'm not testing you on that. What I'd like you to be able to do is if I gave you a group of drugs, what do these treat tuberculosis? So just know, the nice thing is if you ever see a patient come into your clinic or you come across a patient in the hospital and they're on isoniazid and rifampin, should be a red flag. Oh, it's a TB patient. Interesting. It's rare. We don't see a lot of TB in Minnesota. If you do have TB, it's usually because you traveled somewhere and got it, and you're in an isolation room, or you're getting continuous suppressive therapy or treatment. So these are really obnoxious courses. You get 2 months for all 4 agents, then an isoniazid or rifampin alone for 4 additional months, or the alternative. And you actually, with tuberculosis, they make you go in and take it in front of somebody. It's called direct observational therapy, or DOT. It's one of the only times we do that for ID, so it's just a precaution. It's been proven to be more effective. TB, take it seriously, but again, in the United States in general, and Minnesota especially, we just don't have a lot of TB, fortunately. Lyme disease, I'm not going to go through this. You guys have probably all heard about this. Everyone likes to talk about the Lyme cycle. It's interesting, yada, yada, yada. Let's talk about the important stuff. Lyme is very similar to syphilis. Borrelia burgdorferi is a spirochete, and it actually has phases kind of like syphilis too. So if you loop those together, and you remember that doxycycline is an alternative we don't like for syphilis. Well, doxycycline is the primary drug of choice for Lyme disease. Lyme presents as this erythema migrans, so it's this target-like symbol, right? And that's the initial phase. And it's usually pretty easily treated once it's caught. So doxycycline 100 milligrams twice daily for 10 to 21 days. The regimen's debate. Usually I go in the middle, so I do like a 14-day course if I'm going to recommend treatment. So advanced disease can be really problematic, just like syphilis. You can get neurologic implications and cardiac implications that cause damage, and then even if you eradicate the illness, it can be difficult, or the bacteria, it can be difficult to manage the ongoing symptoms. So that's where you get stuff like people talking about chronic Lyme disease, which doesn't really exist from an infectious point of view. Every once in a while, you might encounter a patient who's on really odd long-term antibiotic courses. That's not good medicine, and there's no evidence that says that people with ongoing Lyme complications respond to advanced antibiotic risk. Like I've seen people take like alternating ceftriaxone and levofloxacin IV at home for months on end. It's just going to breed resistance and cause side effects. It's not going to help the patient. That's my 2 cents there. Basically, severe infections we're still treating with doxycycline, but ceftriaxone covers it quite well. It's IV. It's once a day. It's easy to give, so we do that for inpatients who have like advanced Lyme disease. That's our more common one. If they can't tolerate PO, or if we think they're more complicated and want to just go straight IVs. We usually doxy does come IV. We just don't usually do it for Lyme. We do ceftriaxone because it's more convenient as once daily. I put ehrlichiosis on here. There's a couple other tick-borne illnesses that you usually want to screen for when you do for Lyme disease. That's it. That's all I wanted to talk about with that. It's similar treatment. They're usually treated with doxycycline or similar things as well. And that is it. All right. So we have 15 minutes. So I'll leave it open to questions. I know that the big question is, what am I going to test you on? Everything. I kind of spread things out, usually lecture to lecture. This particular segment will be very heavily focused on the slides we just covered. So if you've got some of the antibiotics down and you can apply them to a patient case. So if I give you a cellulitis case and I talk about think about the scenarios and clinical clues I give you. So I'll give you a patient who's coming in, you have no history of them. They report, let's say, STD exposure. What are you going to treat them with? Well, pick the one with the correct doses and the ceftriaxone is azithromycin. So some of it will be basic like that. Some of my cases are a little complicated for fun and also to give you more of a real life picture. There's a funny case on the exam. Hopefully you'll get a kick out of it. But most of my questions I think they're pretty straightforward, and I really do try and guide you towards one correct answer. There shouldn't be situations where you're looking at it and saying, oh, these two both look good to me, but one's maybe more correct. I'll try and give you a very specific direction towards one if you know what you're looking for. I will give you things like sensitivities. So I might give you like a fake little mock-up sensitivity report on the exam. And so you'll see, I'll say that you discharged a patient on cephalexin and Bactrim. It came back growing Staph aureus with these sensitivities, and I'll give you S's and R's for a bunch of different antibiotics, and then ask you what you'd want to do. Do you keep the cephalexin going? Do you keep them going on both? Do you stop one, start the other? Do you stop everything altogether? Those types of things. So that's an example of a test question. The case that I posted online, the cases, I should say. I'll post the key to this soon. We don't have time to go through it today, and that wasn't my intention. But this will give you an idea for how I like to think and how I approach cases. So I'll give you some sort of basic history of a patient. Not this would be too much for an exam to read through, but it'll be more short than this. But anyway, I might give you an allergy. So maybe you're thinking, oh, doxycycline would be a good option for him. Oh, no, he's allergic to tetracycline. So think about those types of clues that I give you, because I will test on allergies. I will bring that stuff up in my cases. So just pay attention to those clinical clues. But that's really how I present a lot of my questions. They're either pretty straightforward, like the ones we just talked about at the beginning of the lecture, where it's really just looking at the drugs. I might ask you about side effects or allergies or something like that. But then a lot of my clinical content, I want it to be case-based. So I'll apply what we just talked about, put it into a patient scenario, and there you go. Yes?
How many questions?
My tests are usually about 45 to 50 questions. And this is the first time I've done online. Somebody scribed them all in for me, so I have to go through and make sure everything looks right. But I don't know. You guys have other online exams, right? And you take them with a proctor in the room still? Okay. So I'll have to figure that out. But yeah, so this is my first time online, so you should get instantaneous feedback almost, I would think, as soon as I can review the stats and everything on them, which I might take a day or so to do before I release. The first exam, I will just give you this. Hopefully it's a little bit of blanket of relief. I do curve my tests, not in the traditional sense, but I throw out questions, and I do take into consideration this is difficult subject matter and it's the first exam with me, so I usually adjust the score and throw out a couple questions if they had really poor response rates, or if the scores are just generally low, I might bump them up a little bit. So, I mean, I don't, it's not to say everybody's going to get an A on the exam, but like, let's say the averages come back at like, 75%, which hopefully they wouldn't, that'd be pretty low. But I might go and look at it and say, okay, which questions do people really struggle with? Are there other points I can give people for certain things? So, but usually people, again, my exam averages probably range between the very upper 80s, like 88 to 92%. It's pretty much where my exams fall. This one tends to be a little lower, maybe 85% average, but that's pretty consistent amongst classes. So it's not, I know it's some of the classes that seems a little bit lower. For this class, that's a bit more par for the course. Yes?
Did you record today's lecture?
I did. I'm still recording right now, too.
So, that'll be
I'll post it tonight, yeah. If I remember. Sometimes it takes a long time to buffer and get up to YouTube, and then I forget about it. But if you don't see it in the next couple of days, shoot me an email, and I'll make sure I get it up there. Yes?
I know that we only have to know the generic and not the brand names, but will, like, the example questions on the PowerPoint, will we see the brand names?
No.
Okay.
So you won't see any brand names.
So, like, Vancomycin will never...
Vancomycin is what you'll see, and for Zosyn, you'll see piperacillin tazobactam. Yeah. I won't ever give you, like, a fake drug either. So, I mean, piperacillin technically exists as a regular form, but I won't give you just plain piperacillin to remember. It'll be piperacillin tazobactam. So if you remember the drug name, it should be okay. I also won't make up drug names like, I don't know, something cyclin or some weird thing like that. That doesn't exist. Yes.
Just to re-clarify with what you said earlier about the pneumonia and azithromycin.
Yes.
Well, can you,
Do not prescribe azithromycin as a monotherapy for community-acquired pneumonia. You can use it in an adjunct. Yep. With the cephalosporin.
Z, that's what I thought.
Yes.
Just clarify.
Yes. People like to prescribe Z-Paks because it's easy. You say, oh, I'll prescribe a Z-Pak, but it's wrong in that case. And that's not just me being annoying. That is an IDSA guideline recommendation, so we're clear.
Yeah.
Okay. I'm always available by email. If I don't respond to you right away, it's probably because you asked me a hard question and I'm thinking about it very carefully. Or if you sent me like 10 questions in one email, I might not